Hey guys, and welcome back to another episode of Surviving Out of Spite. My name is Samantha Sauer, and I'm your host. Today is the first episode of 2026, and it is a good one. I'm joined by the newest member of our medical advisory board, Dr. Eva Alsheik. We talk about everything from the basics of gastroparesis to current treatment options such as the G-PACT and the gastric stimulator from Enterra to new and emerging research. There's a ton of great information in this episode and you won't want to miss, so stay tuned. So, hi, Dr. Alishik. Thank you for being here with me today. I'm very excited to talk all things gastroparesis and the gastric stimulator. And if you would give us a little bit about yourself and your background to get us started, that would be great.
Wonderful. Well, thank you so much for having me. I'm Eva Alsheik. I'm a gastrointestinal motility specialist at Henry Ford in Detroit. And gastrointestinal motility is kind of anything that affects the movement of the GI tract. And part of that is gastroparesis, which, as we know, is a delay in stomach emptying. So, really happy to be spending the next hour or so chatting with you about this.
Yes, we know we love to hate gastroparesis over here, but we do love talking about it. So
Love hate for sure.
it really is. It always gives us something to talk about, but it's not always things people want to hear.
Oh my gosh.
Um, so since you mentioned like the basics of gastroparesis and what actually that does, one of the things we actually haven't done here is get down to the very, very basic parts of gastroparesis. And I think because most of us who have gastroparesis, we have other things going on as well, that it's easy to kind of forget about some of those basics. So for our new people listening or someone who's newly diagnosed, would you mind talking a little bit about those basics and maybe some of the causes of gastroparesis and really the nitty gritty of what gastroparesis really is?
Oh, absolutely. I'd be happy to. So gastroparesis kind of by definition is a delay in the emptying of the stomach in the absence of a mechanical obstruction, meaning there is nothing blocking the end of the stomach, there is nothing blocking the small intestine. It's usually just a slow to move stomach. And when it comes to kind of classifying the big buckets of why gastroparesis happens, we can really kind of subclassify it. So diabetes
Mhm.
constitutes about a quarter of the cases of gastroparesis we see in terms of underlying causes. Then we have a big bucket that we call idiopathic. Idiopathic is just a fancy word for we don't really
We
know.
don't know.
Exactly, and it's, like, highly unsatisfying, but
Yes.
what we do know is that there is this kind of, post-infectious phenomenon, and
Mm,
sometimes we can see this after a really bad gastroenteritis, which means, food sickness,
mhm,
or we can see it after norovirus or adenovirus or even COVID-19. We have seen
mhm.
a lot of cases of gastroparesis kind of in this post-pandemic era.
Yeah.
We can also put, infiltrative causes in that
Mhm,
bucket. So what would that be? That would be kind of sarcoid or anything that kind of infiltrates the muscles. We can put autoimmune causes there, so scleroderma or lupus, for example. We can put our neurologic causes in there. So some patients, for example, with Parkinson's might have gastroparesis. So there's kind of this whole umbrella we call idiopathic, which means we don't really know, but then we can kind of parse it out into these little smaller causes.
mhm,
And then we have iatrogenic, and iatrogenic means it is a result of something that we either had done to us or a medication that we took. So this
hmm,
could be any surgery of the foregut, so the upper GI tract or the chest. So sometimes we can see delayed gastric emptying in patients who have had
mm.
a lung transplant or
Interesting.
bariatric surgery
Mhm,
or hiatal hernia repair, or sometimes even after a cholecystectomy, which means a gallbladder removal. But more and more recently, we are seeing gastroparesis in the setting of medication use. Why? Because we are seeing a ton of patients
mhm,
on these GLP-1 medications, which were originally FDA approved for diabetes management, but now are being used increasingly more in the weight loss space.
mhm.
So this is our Ozempic, our Manjaro, our Zenpep, those types of medications. But in addition to the GLP-1s, other medications that might lead to delayed gastric emptying are opiates. So, a lot of our pain medications that people might get after a joint replacement or back surgery or chronic pain, for example. We can see them even with some antihypertensive medication like
Hmm.
calcium channel blockers. We can see them with some of our depression medications or anticholinergic medications, some of our cancer medications as well. There is a whole host of medications that we can take that can
Hmm.
actually slow down our gastrointestinal motility. So when we meet a patient and they talk about their symptoms of gastroparesis, we always do a deep dive into their medication list and try to figure out reversible or modifiable risk factors, and medications would be one of them. So those are kind of the big buckets of gastroparesis overall definition. And I know I kind of rambled on a little bit, but
No,
hopefully
I
I
loved
covered
it. I
the
loved
what
it
is.
because we haven't done that yet. I'm like, I was thinking about that when we were kind of discussing what we wanted to talk about, and I'm like, we really haven't done that deep dive because so many of us have gastroparesis or are associated with gastroparesis. So you kind of forget about those basics of really understanding what is gastroparesis. And we always want to be cognizant of our newcomers to our podcast, to gastroparesis, and to our community to say, we forget that you don't have all the same information that us veterans do that have been in this space for so long. So thank
Right.
you. That was so I'm like I was just so well spoken. So so I appreciate how easy that is to understand because this disease is so confusing.
Yes. I
And
can only
even just
imagine.
for somebody who has lived with this for so long, and I'm like, yes, I've got it down. I know what I'm doing. And then the next day rolls around and it's like, just kidding. Yeah, I have no idea what I'm doing.
Oh, so
So
frustrating. Yeah. Yeah, it
when
is definitely dynamic.
yeah, and when you understand what's happening, I think it's helpful to make the next step choices, whether that's do I need to see another GI? Do I need to see a subset specialist in GI? Do I need to, move into neuro GI? Do I have to see another specialist for another disease state that might be affecting my gastroparesis? Like you said, doing a deep dive in your medication. Like if you don't understand the disease or where and how it might be affecting you, it's hard to make those next step choices and to be able to say, this is the next treatment that I would be interested in hearing about, or this is the next medication or procedure or doctor, or even just to say to your physician, I'm not feeling well and this is what's going on with me. If you're unsure about what is actually happening with you, like you can say I feel bloated or I'm nauseous or I vomit, but maybe you don't know your trigger foods, right? Or you don't understand what is the typical gastroparesis diet. And maybe we're doing
100%.
something completely opposite of what we should be doing, not realizing that we're not helping ourselves. So it's always good to bring it back to basics and really understand that to make those next decisions. Maybe not easier per se, but easier to understand what your next step might be.
Oh, 100%. I couldn't agree more. And, when you think about how vast the possible kind of differential of
Mhm.
nausea and vomiting alone, right?
Yes.
Like you take those symptoms or you take bloating or early satiety, which means feeling full fast. Each one of those individual symptoms could be caused by so many different things, right?
Yep.
So you take nausea, for example. We talked about obvious things like medications.
Mhm.
Is it something metabolic, right? So if you're having electrolyte derangements, if you're having
Yep.
kidney disease, if you're a
Yep.
dialysis patient, is it something neurologic? Do you, God forbid, have a tumor? Do you just need glasses? Do you have some inner ear issues that are causing
Mhm.
vestibular dysfunction? It's making you nauseous or vomiting. Are you having orthostatic hypotension like we see in POTS disease? Are we pregnant? Like there are so many different things, right, that go through
Yeah.
your head. And sometimes we'll even diagnose gastroparesis, but there might also still be something else going on, right?
Mhm.
So we see a lot of what we call comorbidities, which which sounds like a very serious and scary word, but it just means another medical condition plus
Hmm.
your gastroparesis.
Yeah.
So an example of that is constipation, right? So we see a lot of underlying constipation with gastroparesis patients. And if you
Yes.
don't get that constipation under good control, guess what? You're always going to feel bloated. You're always going to feel
Yep.
full. You might never have your
Hmm.
appetite back. So the whole system is connected. Everything plays with each other. And so you really have to address kind of the whole patient as opposed to just the gastroparesis,
Yes.
right?
Y-
So, yeah, it's
Yes.
always there's so many layers. It's very layered.
Yes. And I could almost hear all the patients after listening to this being like, so where can I find you and
Oh,
how can I see you? Because your addressing of the whole patient or even just saying, how constipation affects your stomach. Like there's been so many times where you talk about these things in appointments and it's like, all right, we'll see you in a couple months. Like just take some Miralax or, just don't eat that again and send us on our way. And we're like, what? And
yeah,
just really knowing that there are people like yourself and some of our other experts that, we've chatted with in the last couple months and really focusing holistically on a patient, it's changing a lot of, I think, the dynamic between the physician and the patient and really making us feel more comfortable having these conversations and not leave the appointments always so defeated trying to treat a
yeah,
disease that feels untreatable sometimes
yeah,
where there's limited options, limited medications, or like we were talking about symptoms, sometimes the medication that you take that helps your gastroparesis might give you another subset of symptoms that you now have to either live with or treat, which means another set of medication or treatments. It's like, I want to get off this hamster wheel, of just trying
yes.
to fix this. But
Yeah. Oh, I can't
yeah.
even imagine. I mean, we see it so often. And then also we see like that spiral, again, just talking about how it's a dynamic disease. I think we're seeing
Hmm.
a lot these days of what ends up morphing into almost like ARFID, which is
Hmm.
avoidant restrictive food intake disorder. And
Yes.
it happens, like, subconsciously, right? Like,
Hmm.
nobody wants to feel sick. Nobody wants to restrict their meals to, like, little bites of white rice, flaky white fish, and,
Hmm.
like, maybe pretzels. Like, nobody
Yeah.
wants that, right? But this develops, and you have to kind of address that food fear, that almost like
Hmm.
sitophobia or that fear of eating,
Yep.
simultaneously with the disease, right? The prokinetic
Yep.
therapy, the Enterra therapy, whatever it is. And so, yeah, it ends up being really like, how they say it takes a village to raise a child. Like it truly takes a village to treat this disease because it
Yeah.
ends up affecting so many facets of your health and your life.
Yeah,
Yeah.
that food fear is something that we've touched upon a lot. And I think especially for me, that's something that I went through and I know a lot of other people go through and that ends up, limiting you on food where you might have some additional choices. But like I don't judge you if you are scared of trying something. Like I've been there, I've been in that
Yeah.
position. I know how scary that can be. And then you isolate from these food-centric holidays,
Yeah.
from different social events, or even just the thought of trying something new, which makes it hard to say, like, where's your issue? It's so, like you said, it's so dynamic. There's so many different things that go into getting better and getting treatment and feeling open to treatment and setting yourself up for success with that treatment as well. Because if you're not addressing the mental health aspect of that and really going into it, with, I hate to say a positive mindset, but in reality, with that positive mindset of like, maybe this won't work, but I'm going to give it a try, in more of a neutral setting rather than, well, whatever, it probably won't work anyway. That doesn't set us up for success. But if you're not addressing that in your appointments with whether it's your physician, a GI psychologist, or a different mental health specialist, it makes it harder for us to move forward, get forward, and get those treatments that we need. So
Oh my gosh,
it's,
I wish you could
it's,
talk to all of my gastroparesis patients because that having that conversation is really challenging, quite
yeah.
honestly, because a lot of patients will come back and say, I'm not depressed. Like I'm depressed because of my symptoms. I'm
Hmm.
not depressed before my symptoms, if that makes sense. Like, why
Yeah.
do I need to see a therapist? And it's our kind of GI psychologist who's associated with our practice, who sees most of my gastroparesis patients. The way I kind of approach it is, listen, you've got this condition. This condition absolutely sucks. It is awful to wake
Hmm.
up in the morning and feel like garbage. And
Yep.
then you start to it's the GI stress cycle, right? Then you start to catastrophize inadvertently. You don't mean to, you don't want
Hmm.
to, but you start to. Your mind goes from 0 to 60. How am I going to get to work today? How am I going to pick my kids up from school? Like, how am I going to get the
Yep.
Christmas tree up? Like, how am I going to clean up? How am I going to do this? How am I going to do that? How am I going to take my car to get an oil change? And then it all becomes very stressful. And then all of those stress hormones get
Right to
released.
the
And
gut.
guess what? Yeah, right to the gut and right
Yeah.
to the heart rate and right to the sweating and right to like that feeling like dry mouth, I'm going to throw up, like all of those things, right? So, what our GI psychologist does is when you wake up and you start to feel those negative thoughts, how can we break that cycle?
Yeah.
What tools can we arm ourselves with to say, this disease sucks, but it doesn't have to be dangerous or life threatening. And I'm going
Hmm.
to breathe through it, meditate through it so I don't get that extra added crappy component to my disease that's going to
Yes.
make me feel worse. Right.
Yes.
And so she has been instrumental in helping kind of like break that cycle before it really
Yeah.
starts to snowball. So yes, I know we digress, but all of this is so important.
Yeah. No, so sometimes when we go off the rails a little bit, it's so good because it's all of those things really they matter and they're not always talked about as much.
Yeah.
We have a lot of different things that we can talk about today and that we are going to talk about in regard to treatment options and what's out there and how to make those decisions for yourself. But if these other things we're talking about are the foundational steps in making those next steps in treatment and understanding that. Like one of the things that I focused on in the last year in our patient community is, we have a lot of information that is directed toward the healthcare professionals. You
Mhm.
want to educate the doctors on the treatments and the medications and the procedures and the do's and the don'ts and all of that. And while that is so incredibly important because we need the experts to be the experts, you also need to focus on educating the patient too. So
Yeah.
that way they understand and can, it kind of brings the expert and the patient together to meet each other in the same place rather than talking all this medical jargon to somebody. It goes way over their head or
Yeah.
trying to explain this is a treatment option. These are the things that could happen. It's unlikely, but these are the things that could happen. If the person doesn't understand statistics or what a black box warning is or what, a certain percentage of people in this group means, like what does that actually mean for the amount of people that this affects? If they don't understand that, they hear black box warning and they bolt and they want nothing to do with it. When in reality, that medication and that treatment could actually be the perfect thing for them. But if you don't explain it in a way where the patient can understand and make that decision for themselves in the best way possible and feel comfortable asking the question to the expert and the expert being able to get the information to the patient in a way that they understand, nobody wins in that situation if we can't make that happen. So these conversations are so incredibly important because we're educating the people whose lives are in this. They are in these trenches. They are the ones dealing with this and need to have the information to make their informed decision on what works best
Absolutely.
for them and
Yeah.
not be afraid to ask questions because I've been in
100%.
that position. I'm just not there anymore. I don't care. But not everybody is comfortable with that or is, like we said, getting back to basics and they're new. They see someone on a feeding tube and automatically assume that that is their destiny. You and I both know that that is not always the case. It could be. It
Yeah.
absolutely could be, but that's not a guarantee with
Yeah.
such a dynamic disease.
And it certainly doesn't have to be a permanent solution, right? It can
Yes.
just be a
Mine
bridge.
wasn't.
Yeah,
Mine wasn't.
that's huge. It's huge. It
Yeah.
is. So no,
Yeah.
I appreciate this conversation so much, especially because I mean, you know how healthcare is now. It's the access stinks, right? So
Mhm.
you could be waiting 3, 4 months to get in with a specialist.
Yep.
And then you could be waiting another 3 to 4 months for your like, I don't know, insurance authorization to get on a schedule, whatever. And then by the time you
Yeah.
get to the office visit, you've got 30 minutes and the clock is ticking. right?
Mm-hmm.
So if you come armed with education and
Mm-hmm.
knowledge, everything's so much smoother in the patient encounter. So I really appreciate this opportunity to kind of
Yeah.
educate and kind of spread the word.
Yeah. So one of the treatments that we did want to talk about today specifically was Enterra therapy, and the gastric stimulator, because I think in the realm of misinformation or just misunderstanding what it can and cannot do and who is a candidate, how maybe, I don't want to say how to become a candidate. That sounds kind of funny, but like what might need to change or not change to make this set you up for success. So that way, if someone is considering this, they've exhausted other options, they can say, well, maybe this is a proper next step for me. And this is the education I want to bring to my doctor. And I can think about the pros and the cons and weighing that out. And, how can this be the most successful for me?
Absolutely. So there is like so much to say on this topic. But the kind
We
of the
could take
first
2 hours.
thing we could take 2 hours on the topic. But the first thing I want to start with is that if you are considering this therapy, go to their website. Their website is actually
Yes.
incredibly helpful. There is a very kind of patient facing component about it. There
Yes.
are liaisons that you can pick up the phone and talk to about this because I find that when investigating new therapies, and this goes beyond gastroparesis, this could be a clinical trial for breast cancer or whatever, right? You just don't know where to start. Like you see, and you're
Yeah.
just like, wait, how do I even begin to know who offers this therapy? And they can kind of talk through your symptoms with you and make some recommendations. So
Hmm.
that's just kind of one aside. Like, regardless of geography, utilize their patient facing services. Okay,
Hmm.
so now that that's out of the way, the candidate for Enterra therapy is basically a medically refractory patient. So what does that mean? That means that you have done all the things, right? You've seen your gastroenterologist. You have undertaken all the diet and lifestyle modifications. If you're a diabetic, you've worked hard on really getting good glycemic control. You have been tried on medications, right? So usually we think of it as kind of two major buckets of different medications that you can take for gastroparesis. Bucket number one is prokinetic therapy. Prokinetic means anything that promotes the forward movement of your GI tract. Bucket number two is anti-nausea medication. So that's kind of like our Zofrans, our Compazines, our Phenergans. Like they help our nausea, but they don't necessarily accelerate the movement of our GI tract. So we have those two buckets. Prokinetic therapy, we're super limited with those therapies. So the only one that's even FDA approved is metoclopramide, which is Reglan, and that was like FDA approved like decades ago, right?
Forever. Yeah.
Yeah, and there are side effects, even though the side effects are exceedingly rare. There's still kind of some neurologic side effects that can scare a patient with good reason. Like that would alarm me too. But the side effect is really low, just so you know. But anyway, even with that, even that medication, which is metoclopramide, we typically recommend as more of a bridge, right? Or short-term use, or if you have
Hmm.
a flare then type of thing. So there's metoclopramide, there's erythromycin, which is an antibiotic, but it also works on the motilin receptors of our gut, and that promotes forward movement. The delivery of that is oral, right? So if you're in a
Yeah.
flare and you're not keeping stuff down, erythromycin like might not be getting absorbed, right?
Hmm.
Same with our other medications. Reglan, thankfully, they came out with an intranasal spray that can be helpful, especially when you're not tolerating anything by mouth. And then we have prucalopride, which goes by the trade name of Motegrity.
Hmm.
That's FDA approved for chronic idiopathic constipation, but also has the secondary benefit of speeding up stomach emptying. And then we have domperidone, which was an excellent medication,
Hmm.
but it's no longer available in the United
Yeah.
States. So you
We
have
have
to
lots
get,
of feelings on that.
yes. So if you want to get it, you have to find a provider who's willing to file an IND through the FDA, get permission essentially for you, be able to monitor you extremely closely to take that medication.
Yes.
Again, really excellent medication. I really hope they bring it back. Very well tolerated, but in a small subset of patients who has a prolonged QTC on their EKG, it could potentially increase their risk of a fatal arrhythmia. And
Yep.
so that's why the FDA pulled it. So again, really limited. Like I just talked about 4 medications in prokinetics. So the anti-nauseants, we have more, right? And that's a good thing. And we have some by mouth and we have some per rectum, like so we put them in as suppositories. We have scopolamine, which is a patch that goes behind the ear. So there are more options there. But again, a lot of these have side effects or they simply don't provide long lasting relief for
Yep.
patients. So if you get to that point, and your predominant symptoms are nausea, vomiting, then you might be a candidate for Enterra therapy.
Mhm.
And if that's the case, I would talk to your gastroenterologist about that, or again, kind of get if your gastroenterologist doesn't know a
Mhm.
lot about it, which might be the case if they're not in a region that kind of readily provides that therapy, and then go on the website and ask for help. But it is FDA approved under a humanitarian exemption device for the treatment of medically refractory gastroparesis in patients with predominant nausea vomiting symptoms.
Yeah, that was so well explained. I'm like, I could sit and listen to you talk all day. It was explained so well.
Oh, good. I'm glad that it wasn't a snooze fest because it can get kind
No.
of technical. So
No, not at all. Now, with that, like I know a lot of people that have had success with the stimulator. I know people that have been somewhat in the middle, and then people that have been unsuccessful with the stimulator. Just like any treatment or medication, there's people in our community that are all across that spectrum of what has worked for them. Now, for me, I don't personally have the stimulator. That was not I don't want to say it wasn't an option for me, but it wasn't really brought up as an option for me. I had other things that were successful, like the G-palm, to where that helped some of the other symptoms, like the nausea nausea never really goes away, if we're being honest, but it
oh,
did help with the vomiting and some of the, digestive issues.
good.
So let's say somebody like me who did have the G-palm, but maybe what didn't have as great success with that because that is an anatomically I'm like, can I say words right?
Yeah.
Altering procedure with the Enterra device. Is that something that I would still be a candidate for if that didn't work as well for me anymore and the nausea and the vomiting was just getting more and more out of control because I already had this other treatment? What might that look like, or what might that change in whether it's the outcome of how I'm feeling with the nausea and vomiting once I'm healed, or would that kind of negate me from even being able to get a treatment like that?
That is such a good question, and we actually did research on it here at Henry Ford. So
That's amazing.
we have a really nice kind of multidisciplinary program here
Hmm.
where we offer, in addition to our dietitian services and our GI psych and our motility, we offer surgical therapy, which would be the Enterra device or pyloroplasty, and then we
Hmm.
also offer endoscopic therapy, which is
Yep.
where you put your Botox in your cheek palm, right?
Hmm.
And we have a lot of crossover of patients. So how do you kind of decide who goes where?
Yeah.
Kind of as a national society of gastroenterologists and surgeons, we don't really have clear guidelines on who is served best with what therapy. A lot of
Yeah.
times it's kind of patient preference, right? They're
Hmm.
like, I don't know if I want something implanted, or, I have terrible migraines, or I have multiple sclerosis, for example. I require head MRIs every
Hmm.
once in a while. Like, can I get the device? Can I not? Or stuff like that, right? So
Yeah.
every patient's a little bit differently. But when you think about the phenotype of patients with gastroparesis, we try to kind of tease out, are they more on the nausea vomiting spectrum, or are they more on the bloating, fullness, early satiety spectrum? Nausea vomiting, we have found, tend to respond better to a neurostimulator, whereas the bloating, early satiety tend to respond better to the GPOM procedure. If a patient has incomplete relief with one of those therapies, can there be crossover? And the answer is yes, there can be. And
Great
can
to
it be
know.
successful? And the answer is yes, it can be successful. We have plenty of patients who have had partial response to a neurostimulator therapy, even after dialing up the energy settings, appointment after appointment. And they're like, you know what, doc, I wish that had more good days than bad, but I can't really report that I do. Then we'll have them evaluated by our advanced endoscopy colleagues, and it doesn't require any additional preparation or anything like that. The device does need to be shut off in the pre-op area. It can be
Hmm.
turned on right in the post-op area. So
That's
it's a
so cool.
really easy on-off, right? It's just like this little. Actually, I have it. Hold on, I can just show you. It's this little device. You put it over the
Hmm.
patient's belly, and then we can turn it on or off, just kind of using this signal,
That's
right?
so cool.
So it's very, very easy. And then even the other way. So we have patients who start with GPOM. And again, it could be because they're in a region where that's kind of the modality of treatment that's offered, or
Hmm.
it could be because their symptoms are more in that like bloating fullness type of spectrum. Or it could be that they're post-surgical patients. So sometimes in post-surgical patients, if you're post-lung transplant, if there is suspicion that during whatever surgical intervention, there could have been some injury to the vagal nerve, that's the nerve that kind of supplies the motor to our stomach.
Yeah.
If there is a suspicion of that, we typically actually offer G-POEMs first. Can there
Okay.
be crossover of therapies in those patients? Sometimes. It really
Sure.
depends on the patient. Certainly, if the patient got a G-POEM first and they do not have a surgical cause or an etiology to their gastroparesis, absolutely we can offer that treatment for them if they're interested. So the short answer is yes, there is. You can have kind of crossover in therapy
Mhm.
with success. There's data to prove that.
Yeah,
Thankfully,
that's so great to know because I know that that is something with any treatment. It's like, well, I had this, so that disqualifies me, right? Or, well, that didn't work, so this isn't going to work for me. And it's hard when, the research isn't there. So I'm glad
yeah,
that it has started to. I love when people are like, there's research happening. I'm like, finally, like it's
yeah,
about time, right? To have that there. So when people come to us and ask these questions, we can say, hold on, let us get you that information. So again, you can make that decision. Cause I've known, like, I had a very successful GPOM. My physician, he was amazing. He's on our medical board and he's been such a great resource for us and just for me personally ever since we met. And it took him a while to convince me to do anything because I was terrified of any
yeah,
changes. I'm like, I'd rather live with the evil I know instead of like doing something and then what if it's worse?
yeah,
It took a while for me to come to terms with I need to make a decision. But in the last maybe year or so, I've noticed an uptick of the gastroparesis symptoms. And now because I have comorbidities. I have other
yeah.
things that lovingly affect my digestion where I'm like, thanks. Um, you know,
Oh,
you
yeah,
never know, like, because the G-PALM is not, a 40, 50-year long, FDA approved treatment to where there's longevity to say, well, 50 years later, this person is still at maybe, only 10% less than they felt right after they healed, right? That's
yeah,
not there. So the answers aren't there. So I'm
yeah.
like, well, as these things start to happen, does that make something less effective? Or does that just mean that other things have gotten a little more out of control? And that's what I need to get under control to get the stomach and, motility, GP symptoms kind of back to the baseline that I got used to post GPOM.
Yeah.
And the hard part for that is it's very difficult to find an answer for that when you've got all of these things that bump into each other all the
Oh,
time.
100%.
And when you're talking about it takes a village, I'm like, okay, but who do I talk to? Right?
Yeah.
Like where do I start? So I think just knowing that there is other research out there connecting these treatments to those treatments, what candidate fits under which treatment, whether that's patient preference, like you said, I've got a port, I've had implanted devices, and as a diabetic, I'm used to things just being attached to me all the time.
Yeah.
Like that might not bother me, but I can completely understand why that might be something where someone's like, I know that this could fix me, but I really don't want to go through a surgery. Maybe
Yeah.
they've never had surgery before, and that is literally invasive. So you might
Yeah.
not want to do that and try something else first. So just knowing that the information's there is really great.
I think that what is compelling about this specific therapy is that it can be reversible, right? Like,
Yes.
even though it's a surgically implanted device, guess what? We can take it out too,
Mhm.
right? That thing does not embed. The neurostimulators do not like burrow into your stomach and become part of you forever. No, we could just pull them out and then close you up and then you're done. And it's
Yes.
it's not it's not a big incision, right? It's
Mhm.
just it's small. It's like an old school flip phone, like maybe half that size. It's very
S-
reasonable. It's low profile.
So
It's thin.
cool.
Yeah, it's just right under the skin. If you're somebody who's very thin, it might be more noticeable and palpable,
Mhm.
but for the most part, you don't even notice it's there. So they're working on kind of the next iteration of an
Mhm.
Enterra. So, technology is great.
That's
So yeah,
insane.
it is really insane. So we have a lot of patients who come to us who say, I don't want to get the G-POEM because it's irreversible. This
Mhm.
is, I mean, and technically it is, right? But I think that a lot of the scaries about G-POEM, I have actually never seen them like a lot of my patients will say, I'm really nervous about dumping syndrome.
Hmm.
In all of the years that we've been doing G-POEM, which I believe has been, gosh, we're going on 8 or 9 years now, we have not seen one case of dumping, right?
That's
But
amazing.
it is really compelling that the Enterra it's irreversible, right? Like if you are in
Mhm.
that really small subset of patients and who it doesn't work, we do a shut off protocol, meaning that we shut it off while it's still in your body. If after 4 weeks you really have not noticed a change, then we'll explant it, no harm, no foul.
Mhm. Now, talking about explaining it and the reversible aspect, I know that it does have a battery life. And
Yes.
the higher, and you could please correct me if I'm wrong here because I might use the wrong words, but the higher like the frequency is on the device, the quicker you will drain the battery. So
Hmm.
if you are somebody that, you start low and move your way up, some people do really good at the low level. Some people need to continue moving it up, which makes sense depending on the severity of your disease. But if you're using that at the highest it can go, what does that look like in like battery changes or the frequency? How many times might you need to go in for surgery, to get the
Yeah.
battery replacement? Or what does that look like? Because that could be a deciding factor for
Yeah.
somebody knowing that there's like you're a repeat customer, right? So what
Yeah.
what type of repeat customer are you going to be with this type of device?
Of course, that is such a good question because honestly, nobody wants to go under the knife more than they have
No.
to, right? And usually, when we do turn up the settings, it's for a compelling reason, and the patient's responding to it, right?
Mhm.
So they understand that and understand the risk that they might have to come back for a yearly battery exchange. The kind of
Interesting.
bigger
Okay.
procedure is the initial implant, right? Where we actually place the leads and suture them to the stomach.
Mhm.
After that, subsequent battery exchanges are very kind of superficial outpatient type surgeries, right?
Mhm.
And the patient is usually in and out. We might admit them overnight for those battery exchanges just to ensure that their pain is under good control. Usually it's an
Okay.
under 24-hour admission, so it's not super disruptive. Of course, you have
Mhm.
all of the post surgical precautions like not lifting anything heavier than 5 pounds for several weeks and things like that. But for the most part, the first one is kind of considered the bigger surgery, even though it's the quote bigger surgery, it's still very, very well tolerated. But you're absolutely right. If you are on what we call factory settings, which is I open up the box, I put it in the
Mhm.
patient, and they're just kind of like the lowest possible settings, you're
Mhm.
looking at almost a decade of battery life,
Oh,
right?
wow.
And some patients do so well, percolating along 8, 10 years they get out of that battery, right? But if
Mhm.
you're on the highest energy settings, you might burn through your battery in a year.
Oh,
And
wow.
so we always have that conversation. Look, we're moving from a low energy to a medium energy to a high energy protocol. This
Mhm.
is going to drain your battery life. Are you okay with it? And for the most part, if a patient feels like they are improving, they're kind of willing to undergo that yearly battery
Makes
exchange
sense.
because they're having more good days than bad and they're able to live their life, right? Others
Yeah.
are like, oh, absolutely not. I don't want to go under the knife that frequently. So it just kind of it's a conversation that you have to have individually with each patient.
Yeah, which that makes sense. There's a trade-off with everything, right? No matter
Yes.
what you choose, whether it's a medication, a treatment, procedure, any of these things, there is that trade-off. And really, it's so different for everybody. And I know like for the amount of surgeries I've had, I'm like, oh, I don't know how I would feel about that, to go
Yeah.
in every single day. But I also know how much I value and how grateful I am for my good days that I can imagine if I'm able to have a relatively normal life, or if I'm able to really do things like I never thought I'd do again, or eat things that I never thought that I would eat again with so much less nausea and vomiting, that's a pretty good trade-off in my opinion. But
Yeah.
again, that's going to vary person to person. And
100%. Yep.
they might still be on a very limited diet because one of the misconceptions, and you touched on it earlier too, about how this works is like, it's for your nausea and your vomiting. Like it's not, um, the
It's
frequency is not there to make your stomach start doing this again.
yes,
It's
exactly. It
not there
doesn't
for
have
motility. And I think
yes.
that's so easy. Like I know that I thought that when I first heard
Oh,
about the
yeah.
therapy all those years ago, I'm like, wait, like sign me up. Yeah, please, like, make it work again, feeling like a little Frankenstein stomach, like it's, it's alive, like it came back, it's working again. And they're like, nah, that's not what it is. I was like, oh,
Yeah. It does not
okay.
pump and empty your stomach by any stretch of the imagination. I know that it's a common misconception because a lot of people refer to it as the pacemaker, right? And the
Yes.
pacemaker, I don't know, we think you would need a car-sized battery to get that kind of pumping and emptying again, right? But that's not what it is, right? It kind of works with the nerves to kind of reduce the nausea and
Yes.
vomiting. So it is a very cool technology. We are understanding kind of the pathophys behind that more and
Hmm.
more every day. And again, we are very lucky that Enterra is like a socially responsible company slash entity.
Yes.
It's
Yes.
really trying to get to the cellular and ultracellular mechanisms of
Hmm.
how this works and ways that this technology can be applied, even in different non-gastroparesis settings.
Hmm.
So it's actually it's very cool. I think we've kind of seen the tip of the iceberg with regards to how it can help, and I
Yeah.
think that the next few years will be really, really insightful.
Yes, and I know there are some other clinical studies happening, starting, I forget which phase, they're in right now, which again, it goes back to one of the things we as a whole from our community have felt for so long because of the lack of options is you feel forgotten about. I had a
Mhm.
conversation very recently with some patients. They're like, is any research even happening? I'm like, actually, yes. Like, this is the first time I can tell you, like, some things are happening. And
Yeah,
it's been from the boom of people being diagnosed post
yeah,
COVID, GLP-1s, or actually just getting the proper testing and actually getting their diagnosis. And it's like,
100%.
we wish you weren't here, but we're happy to help you, now that you're part of the community here. And I think that it's been so frustrating from the, patient perspective. Like, does anybody care? Like, you guys are all going home and you're eating your breakfast and you're eating your
Yeah,
dinners and you're doing all the things and you feel perfectly fine. Like, must be nice,
yeah,
while we're sitting here waiting not patiently anymore for something to change. And
yeah.
it's just so great to see. And I know, the mission behind Enterra and what they stand for is something that, we have always appreciated as a community for so long. And to see the changes, to see how, like you said, of being socially responsible and to really say, what else can we do? Not like, let's just make something, make our money and bolt. Like, that's not the mentality here.
Yeah,
And I think that that really is what sets them apart as a company from others, because there
yeah.
is so much true care for our community to say, how can we better assist you? How
Oh,
can
yeah.
we better educate you? Like, even back in the beginning, you're like, call them, like they will help you,
Yeah. Yep.
and that's huge. You don't A lot of companies and or pharma companies, medical device companies are doing that now, but they've been doing that for a while. So they set the
Yeah.
standard a long time ago for
Oh,
that.
absolutely, and there are, like, patient webinars with Q&As, and
Yes.
so where you can talk to kind of the experts and they're not only big into education, they're big into advocacy, and we have really, sunk our teeth into delivering virtual care, here at
Yeah,
Henry
which is
Ford, and so
wonderful.
yeah, it's wonderful because then we can see patients even if they live 9 hours north of us, right?
Mhm,
So it's been kind of really helpful and, I feel like hope is such a big component of delivering care, especially as it pertains to this disease process, right?
mhm,
So, just kind of letting a patient know, we have a lot of we, even though we think that the options are really limited for gastroparesis, we have more tricks up our sleeve than you'd think, right? So
yeah,
we've got
yeah,
we've got medications, we've got the GNS, we've got G-POEM. Like if it gets really, really bad, like you know surgeries directly to the stomach might be an
mhm,
option. We have feeding tubes. We have TPN to get you over the hump. Like there's all these and then we can layer on meds on top of those therapies. So
mhm,
so the we're never quite finished. Like we never feel like
yeah.
we've reached the end of the road and that's different than it was 15, 20 years ago.
Yeah, absolutely. I know when I was first diagnosed, back in 2014, I believe, it was so different than it is now. And, not a ton has changed, but I think some of that comes with my advocacy and, what I've learned as a
Yeah.
patient and what I've been through too. Like, at this point, I don't my GI is great. I love her, but I'm way too complicated for her, unfortunately, to where I'm like, I'm very limited in my small area on like
Yeah.
what next steps I can do. And then to add on to insurance limitations on travel and coverage. And
Yeah.
you said it before of how long it takes to get things done. And we're just
Yeah.
here, trying to deal with that. But it's a very slow moving process, and unfortunately, I don't see that changing anytime soon. Things have improved in our world, and we have, you know, groups like Enterra, we have physicians like yourself who understand the patient better than I think we have in years. And, it sets the standard for physicians, which is why I said in the beginning, people are going to be like, what's her number? Because like, can I call her? Because they're really gonna they're in positions where it's like, I don't know what to do with you. Like, I
Yeah.
just come back or don't. Like, I don't. We have so many patients with those horror stories, and it's like,
Yeah.
did they offer you X, Y, or Z, or talk to you about this, or refer out, and they say no? We're like, okay, hold on. Like, that's got to change too. And
Yeah.
we are, again, slowly but surely starting to see more neuro GIs, more motility
Yeah.
specialists, and more GIs as a whole who are really just like, we want to do better by our patients because we're seeing these and their quality of life is in the toilet and
Yeah.
nobody deserves that.
I
So,
will tell you that in some smaller communities, all of this is surgeon driven too.
yeah.
So it's so kind of second nature to be like, oh, I need a good GI to
Hmm.
kind of figure this out. But one of the surgeons that I work with through Enterra, he does all of it, like A to
Yeah.
Z. Like he's the guy in his
Hmm.
community, and so I would just urge patients to kind of get creative and look outside the
Yeah.
box. And sometimes you find kind of these gems, even in kind of smaller, more rural areas, who really take care of all of it, which is
Yeah.
really, really cool to see. So just kind of another lever that we can kind of pull on
Yeah.
to try to see if we can
Yeah.
find a treasure, right?
Yeah. No, that's it's great. And, those are things that people don't think of, and you get defeated and kind of get stuck in a situation where you're like, well, I guess this is as good as it's going to get for me. And you stop looking forward, and no one can
Yeah,
blame you for that. I've been in that situation, and a lot of us get in that place where
yeah,
you're like, I don't know what to do anymore. And
yeah,
that's that just amplifies our desire to want to get these conversations out there, to get the information out there, to say, like, let's get together, let's support each other, let's talk about
yeah,
these things, let's get this information out there. Because when you can't eat, or when you eat and you're miserable, and nutrition is required to survive, hydration is required to
yeah,
survive, our lives revolve around breakfast, lunch, and dinner. And our
yeah,
holidays revolve around special food or special
everything.
events that there's
Sure.
food everywhere. And it's like, when that becomes your worst enemy,
Oh,
it's
it's
so difficult.
devastating. Yeah,
And learning that new normal and adjusting to that, like, we adapt, because if we don't find ways to adapt, we won't survive this,
yeah,
and that's really important. But I think acknowledging the impact of that, and then what is needed to get through that mentally, physically, emotionally, now that that's become more of a conversation and is happening within the conversations, I see a light at the end of the tunnel. It might not be a
good.
cure, but I do see better treatments coming. It might not be for our generation. It might be for the next G-PACT generation coming in to say, hey, we got the first line of treatment, like, of this really, really great thing. And we've reversed gastroparesis. Like, who knows what's coming? But I think
Yeah.
the more we do this, the more likely that we have a chance of that happening. So,
And I would just ask you and beg you and urge you to keep amplifying that message of hope,
yeah.
honestly, because I think that the most dangerous thing are kind of negative echo chambers.
Yes.
Because I think that there is so much therapeutic benefit to hope and positivity.
Yeah.
When you feel like so terrible for so long every
Yep.
single day, it is so easy to just plunge into darkness, right?
Yes.
But being the light like you are, and for sharing your story and being optimistic about the future and about the research that's forthcoming and about the providers and the companies that are dedicated to this mission of making this
Mhm.
better. Like we're out there, right?
Yeah.
So,
Yeah.
so keep that message of hope going. It's incredibly impactful.
Yeah. I will always sparkle a little dark humor in there, but you can,
Well, good.
but
That's what
it's
makes you
important.
authentic and genuine, right? That, I mean, really, that's you're a realist, but an optimistic realist. If I just created
Yeah.
a subset.
No, I'm going to use that from now on. That's going to be me from now on. So, well, thank you so much. This has been a wonderful conversation. And, I can't wait for everybody to listen in and just hear more about what's coming, what's happening, and how to make informed decisions for themselves. And, it's a wonderful thing to feel supported by the people who are the experts and, really digging into that and making those decisions that we as patients can't make, but to see that and then help guide us to, as cheesy as it sounds, live our best life, right? Like, you can't necessarily make it all go away. We can't fix everything, but we can do what we can to get you to a better place, a healthier place, and, just really do what we can for you. So thank you so much for this. We really appreciate
Oh,
it.
it's my absolute pleasure. And thank you for having me. This is my first podcast. So this is really
Really?
exciting. Yeah,
Yay.
it's my first
We
podcast.
are
I
so
can't wait to hear
honored.
it. Oh my gosh. Well, I know I'm going to listen to it and be like, oh my God, that's what I sound like. Ooh.
You get over that real fast. That was me in the very beginning where I'm like, "Oh God, I talked about that on the internet." And now I'm just like, "Whatever, like this is me, guys. I'm sorry.
Yeah.
It's
Welcome.
what it
Like,
is."
join the circus, right? So, well, thank you. And if I can be of any help to you or your community, please know that
Mm,
I'm more than happy to do so.
yes. Thank you so much.